Navigating Gynecomastia in the male enhanced bodybuilder. Hello, everyone. I'm John Jewett. I'm the owner of J3U University, and we elevate the coaching industry standard for education. So today I want to address gynecomastia, which when working with athletes, it's one of the most common issues that I do come across in cycle design, and how to navigate that as a coach or just a user in general can be confusing, and it's where I get a lot of questions on. So I want to dive into that a little bit today. Now, the main thing is, what is gynecomastia? And it's just a relatively benign increase in the glandular tissue of the male breast underneath the nipple. And how does this mainly occur? A lot of people want to blame estrogen, but you really need to think of the ratios of androgens to estrogens, as in general, androgens cause a decrease in breast tissue, while estrogens cause an increase in breast tissue. And so when we see this growth happening, it's really a change in alteration in these ratios, where estrogen is becoming more pronounced and the androgens are becoming less. And so this can occur in different scenarios, but typically for the enhanced user, it's usually when we're bringing up the androgen level, and estrogens in turn are coming up if you're using aromatizing compound like testosterone. Now, this isn't always the case. It can be even when some guys are coming off cycle, there's a lowering of androgens and there's enough estrogen present that those ratios get offset too. But really, it's these ratios. So we're looking to first address it. We're going to need to addressing the androgen to estrogen ratio. Now, some other things to bring up would maybe be prolactin and progesterone. Although these might have some influences, and they do have receptor sites around the breast tissue, they have more permissive role. So prolactin might cause a decrease in androgen receptor effectiveness. And so in turn, it does have a more of an anti-androgen effect in making the estrogens more pronounced. However, the main things to really address here are still estrogen and androgens. And when we look at these things of when this starts to symptomize, is you start to have some type of sensitivity or pain around the breast, and there is a pseudo gynecomastia and actually gynecomastia. So a lot of people might be in the off season starting to gain some body fat, realize their nipples look a little puffy, and what you could feel right around the nipple area, and you won't feel anything that has a nodular appearance or feel to it. With actual gynecomastia formation, should be like a rubbery disc formation when you pinch around that breast tissue, and that would be the actual gyno rubbery tissue of the breast versus just body fat. And that's how you differentiate between those two. Now, if you are bringing up these compounds and dosages and you're noticing this occur, what we do on the coaching front is we want to be altering our androgen to estrogen ratio as a first strategy. That way we don't always have to stay on these SERMs or aromatase inhibitors, as it's simply skewing your androgen to estrogen ratio. So the first thing I look at is the stack design. How can I lower the estrogen input? That's typically just lowering testosterone back to the previously established dose someone was tolerating it at. And that milligram comes down, I might bring up a milligram amount of something that doesn't aromatize. This could be a DHT derivative of masteron or primobolan in turn. And an interesting thing to note is a DHT has actually been highly effective in the treatment of gynecomastia. It just also comes along with other side effects, why it's lend more things like SERMs as a mainstay treatment over DHT. But realize that just bringing in more DHT derivative absolutely could already start the process of reducing your gynecomastia symptoms. Now, what do you want to do as you alter the stack design, lowering testosterone and bringing up your DHT derivative? That's going to take a little bit of time to work, as those esters will have a prolonged effect. So what do you do in the meantime? So you might be a case, if someone has a more robust response of acutely, we need to put in something to bring down that estrogen input. And what we see across the board that is still the mainstay treatment and where we have the most evidence for is tamoxifen, Nolvadex. For treatment where 3 to 9 months has shown up to 90% effectiveness in reducing gynecomastia. Now, if this has been something that you've had for over a year or even 2 years, that tissue might have become more fibrotic and harder to where it's not going to have an input by changing your endocrine system through using something like a SERM. So if that's the case, you won't be able to do much about it. It's really surgical intervention at that point. Now, so what we do is we implement one of these things like a SERM, typically Novodex or tamoxifen, also known as, because that's what's been shown the most evidence for. And having that in place acutely, while in the background, the esters are now changing and accumulating, and we're lowering their testosterone, and that stack design is coming into fruition, then we can remove that SERM, and now we continue on with our cycle. So that's just a basis of how we would go about if gyno is starting to come up. We alter the stack design to skew androgens to estrogens. We might acutely add in something like a SERM and then remove it once the stack design has come to its full fruition. Now, why an aromatase inhibitor might not be the best suited in this case is it's shown poor efficacy in the research of actually reducing gynecomastia. Also, we're going to be reducing with an AI our total estrogen pool, which we actually do want estrogen. It has a lot of beneficial effects. We just don't want it having an impact at the breast tissue. And with something like tamoxifen, for instance, it has an agonist effect on the breast, but it also has other beneficial effects. For one, it has a protective role around preventing oxidation of LDL cholesterol. So it has some protective effects around the heart. It also has been shown in states of low estrogen utilized in skeletal muscle to increase muscle force contractility. It even can stimulate bone production in women that are postmenopausal. So we don't want to lower all of estrogen pool. And that's why Novodex might be a little bit more preferential. But again, either way, we're using these things acutely. So if you want to learn more about this, of what you might be doing, specific questions to your own process of addressing gyno, head to j3university.com. We dive more in depth there, and you can ask me questions in the forum as well.